Today we are going to talk about Equine Metabolic Syndrome, or EMS, versus Pituitary Pars Intermedia Dysfunction, or PPID, in horses. These are two major endocrine disorders that can both be associated with laminitis, but their pathogenesis, diagnosis, and treatment are very different. Let's start with EMS. The central abnormality in EMS is insulin dysregulation. Genetically susceptible horses, particularly many pony and easy keeper breeds, may develop an exaggerated insulin response to dietary carbohydrates, peripheral insulin resistance, decreased hepatic insulin clearance, or a combination of these abnormalities. The pancreas compensates by secreting more insulin, producing hyperinsulinemia. Chronically elevated insulin is especially important because it can directly contribute to hyperinsulinemia-associated laminitis. One proposed mechanism involves abnormal stimulation of insulin-like growth factor 1 receptors within the hoof lamellae, leading to dysfunction of the lamellar tissues. Clinically, horses with EMS are often overweight with a body condition score of 7 out of 9 or greater, although lean horses can also develop EMS. Common findings include a crusty neck, abnormal fat deposits over the head or shoulders, difficulty losing weight, and previous or recurrent episodes of laminitis. Diagnosis focuses primarily on insulin rather than glucose. After approximately a 3 to 6 hour period without feed, a resting insulin concentration greater than about 45 micro-international units per milliliter may support insulin dysregulation, although specific reference ranges depend on the laboratory and assay being used. If resting insulin is normal but EMS is still suspected, dynamic testing can be performed. During an oral sugar test, corn syrup is administered orally and insulin is measured approximately 60 to 90 minutes later. An insulin concentration around 45 micro-international units per milliliter or greater may support insulin dysregulation. An oral glucose test can also be performed. With commonly used protocols, a 2-hour insulin concentration of approximately 65 micro-international units per milliliter or greater is considered abnormal. Importantly, blood glucose itself is often normal in horses with EMS. A normal blood glucose concentration does not rule out the disease. Treatment primarily focuses on reducing insulin concentrations and improving insulin sensitivity. High sugar and high starch feeds should be eliminated or greatly restricted. Pasture access may also need to be limited, especially during periods when grass contains high concentrations of sugar. Forage should generally contain less than about 10% non-structural carbohydrates. Obese horses may initially receive approximately 1.5% of their body weight per day in forage, with careful monitoring to produce controlled weight loss. Once laminitis is stable and exercise is considered safe, regular exercise can improve insulin sensitivity. Some difficult cases may also require medication. Metformin may help reduce the insulin response following a meal, although it has relatively poor oral bioavailability in horses. Another option in severely affected horses involves SGLT2 inhibitors such as vilogliflozin or canagliflozin. These medications block glucose reabsorption within the kidneys. This causes more glucose to be eliminated through the urine, decreases circulating glucose following carbohydrate consumption, and reduces the amount of insulin that needs to be secreted. Now let's compare EMS with PPID. PPID is primarily an age-associated neurodegenerative disease involving the pituitary gland. Dopamine-producing neurons traveling from the hypothalamus to the pars intermedia progressively degenerate. Normally, dopamine inhibits melanotroph cells within the pars intermedia through dopamine D2 receptors. When these dopamine-producing neurons are lost, that inhibitory signal disappears. The melanotroph cells become excessively active and may undergo hyperplasia or adenoma formation. They then produce excessive amounts of hormones derived from proopiomelanocortin, including ACTH, alpha-MSH, beta-endorphin, and CLIP. This produces a very different clinical picture. PPID typically affects older horses. Clinical signs include delayed shedding or hypertrichosis, muscle wasting along the top line, a pot-bellied appearance, lethargy, excessive sweating, increased drinking and urination, recurrent infections, and laminitis. Laminitis risk becomes especially important when PPID occurs together with insulin dysregulation. PPID and EMS can occur in the same horse, so diagnosing one condition does not automatically rule out the other. For PPID, diagnosis primarily involves measuring plasma ACTH. There is not one ACTH cutoff that can be used throughout the entire year because ACTH concentrations normally increase during certain seasons, particularly during the autumn. ACTH results therefore need to be interpreted using seasonal, laboratory-specific, and assay-specific reference intervals. If the basal ACTH result is questionable, a TRH stimulation test can be performed. During this test, ACTH is measured before and after administration of TRH. Horses with PPID typically produce an exaggerated ACTH response. Treatment for PPID primarily involves pergolide. Pergolide is a dopamine agonist, particularly at dopamine D2 receptors. It essentially replaces part of the inhibitory dopaminergic signal that has been lost because of degeneration of the hypothalamic neurons. This suppresses excessive activity of the pars intermedia and decreases abnormal hormone production. Treatment commonly begins at approximately 2 micrograms per kilogram once daily, although the dosage should be adjusted based on the individual horse, clinical response, and follow-up testing. Finally, prevention differs between EMS and PPID. EMS can often be prevented or its severity reduced by maintaining an ideal body condition, controlling dietary sugar and starch, carefully managing pasture access, and providing regular exercise. PPID itself cannot currently be prevented because the underlying degeneration of dopamine-producing neurons is associated with aging. Instead, management focuses on early detection and monitoring of older horses. Owners and veterinarians should watch for abnormal hair coats, muscle loss, excessive sweating, increased drinking and urination, recurrent infections, and laminitis. So remember the main difference. EMS primarily involves insulin dysregulation and hyperinsulinemia. PPID primarily involves degeneration of dopamine-producing neurons, loss of dopamine inhibition of the pars intermedia, and excessive production of pituitary hormones. And in an older horse with laminitis, consider testing for both. If you have topics you would like to suggest or donate to our video and game development, reach out to dogtoursgame@gmail.com.